Okay, thanks, Dr. Levy. I'll get started. So, hi, everybody. My name is Dan Eichberg. Today, I'm going to be talking about connectomics. So, connectomics is considered to be this extremely esoteric subject that only.
What's that?
Can you say it again? Okay. This extremely esoteric subject that only some of the nerdiest neurosurgical oncology people are interested in. But I'm here today to make the argument that it is actually very important for everyone in neurosurgery to have at least a basic understanding of connectomics. So what is connectomics? It's basically the anatomy of the important white matter tracts that power our brains and enable us to think. It helps us plan safer surgeries and perform the surgeries in a safer, faster, and more efficient way that gets more surgical enterprise from your surgeries. So just an overview of the talk, we're going to talk about why better glioma surgery matters. Connectomic anatomic knowledge is important for all brain surgery, but it's especially important for glioma surgery. We'll talk about how the telencephalon works. Obviously, there's white matter tracts throughout the entire central nervous system, but the focus of my talk will be on the white matter tracts of the telencephalon. Major white matter tract anatomy, higher cognitive function networks, and the underlying white matter tracts that power their connectivity. And then finally, applied connectomics for brain surgery. So different brain surgeries that we do, what are the important white matter tracts that are close by or could be involved, and how do you navigate these areas? So I'm going to start with a word on nihilism in brain tumor surgery. So, is this, I'm going to ask the question, is this MRI operative? So this is, for example, a 20-year-old male dove into a shallow pool, ASIA A, spinal cord injury, bilateral jump facets. Is this operative? And, we know that the data is not great in terms of the potential for recovery. In terms of being able to walk again, very low percent chance of being able to walk again with a cervical spinal cord ASIA A injury. However, I think almost everybody listening to this talk would agree that this is definitely not just surgical, but an emergency surgery, because even though the chance of walking is very low, we still want to give this person every possible chance at being able to walk that they deserve. If this was, my scan or my family scan or my friend's scan, I would want them to have the surgery just to be able to give them the chance. And I think that's completely reasonable. So similarly, glioblastoma is well known to have a very poor prognosis, an average survival of about 14 months. There's a lot of nihilism with glioblastoma. Why even put these people through a surgery? Maybe just do a biopsy, send tissue, and then give chemotherapy and radiation therapy. But by definition, 50% of glioblastoma patients survive longer than average. Okay, and if you look at more recent data since 2005, survival rates have been slowly creeping upwards. The 3-year survival rate of 11%, and a 5-year survival of 3%. And we all know patients who have been living for 10 years or more with glioblastoma. And obviously, these numbers are not very encouraging. I wouldn't want to have this sort of a survival number for myself. But one thing that I would want is to be able to at least have the chance of being able to be put into one of these longer term survival categories. And I can almost guarantee that every single person that has glioblastoma that survives longer than average has had surgical resection. They did not just have a biopsy or just radiation and chemotherapy. They all had aggressive surgical resections of their tumors. So we owe it to our patients to give them the best possible chance for the longest possible recovery or survival. So what does the data show? The data shows that in newly diagnosed glioblastoma, there's a dose-dependent relationship between how much cytoreduction you perform, meaning how much volume of enhancing tumor you resect, and length of survival. So the more volume of enhancing tumor you're able to resect, the longer the patient will survive. And that's been replicated in many large-scale studies. Same thing in recurrent glioblastoma. The greater the volume of the enhancing tumor that you resect, the longer the patient will survive. Again, been replicated multiple times. But it's not just about how much enhancing tumor you resect. You also want to preserve the neurological function of the patients, because many studies have also shown that when you start causing neurological deficits, or at least permanent neurological deficits, you start decreasing the survival of the patients. This paper from the White Journal I thought was very interesting because it showed that permanent post-op neurological deficits decrease survival, but one of the longest surviving categories was actually temporary neurological deficits. This wasn't a statistically significant finding, but it was still a finding that I think makes sense. The way that I interpret this finding is that patients that have extremely aggressive but safe tumor resections that are able to take the limit of the resection just up to the areas that control function, but are still able to recover their function, survive the longest. So basically this translates into something called the oncofunctional balance. This is a term that Hugh Defoe coins. And basically there's a balance between cytoreduction. So the more tumor you remove, the longer the patient will survive. But of course, in intrinsic brain tumors, the tumor cells in the brain are sort of the same thing. The tumors are embedded within the tumor cells are embedded within the brain itself. So the more cytoreduction you perform, eventually you reach a point where you're starting to compromise neurological function. And we know that neurological function preservation is important for survival. So you need to try to strike an optimal balance between resecting as much tumor as possible while preserving as much neurological function as possible and giving patients a roadmap towards neurological recovery. So, this is a figure from a very famous paper. This is from the 1986 paper, the original Spetzler-Martin AVM grading scale paper. And it basically, among other things, divided up the brain into eloquent areas and non-eloquent areas. The reason I'm bringing this up is because if we want to help preserve, we want to perform aggressive surgical resections and preserve people's neurological function, we need to have a good map of the brain and how it works and how we can safely navigate the brain. So even though this Spetzler-Martin figure is not intended for guiding brain tumor surgery, I think if we're honest with ourselves, a lot of our core understanding of how the brain works is kind of summarized in this picture. It's not such a bad picture when you think about it. So they divide up the brain into these colored areas, which they term eloquent, and AVM surgery is riskier in these eloquent areas. And AVM surgery in the gray areas, the non-eloquent areas that they termed, is considered to be less risky. But is this really the entire story of how the telencephalon works? Are the gray areas really spare parts that are disposable? And obviously, these color-coded eloquent areas are just in the cortex of the brain, the gray matter. But what about the underlying white matter? Does the white matter? Is that worth preserving? And I think that pictures like this lead to the commonly held, phrase that is used, which is we only use 10% of our brains, because if you look at the colored portion of the brain is probably only about 10% of the entire brain. So is that true? Do we only use 10% of our brains? And the question is, would a map like this cut it in any other neurosurgical subspecialty? If we only knew 10% of the wiring diagram of the basal ganglia, would that be good enough for functional neurosurgeons? If we only knew 10% of the function of the cranial nerves, would that be good enough to guide skull-based surgery? If we only knew 10% of the white matter tracts in the spinal cord, would we be able to do intramedullary surgery in the spinal cord? And in the brachial plexus, if we knew only 10% of the function of the brachial plexus, would we be able to do complex brachial plexus surgery? I've tried this experiment. I've told Dr. Levy in morning conference that I only knew what 10% of the brachial plexus does, and he didn't like that answer. It didn't work out well for me. So I think that if we can strive for a higher level of understanding of how these other parts of the nervous system work, we should strive for a better understanding of how the telencephalon works. So where do images like this map come from? That came from the Spetzler-Martin paper. They come from something called the localizationalist view. And the localizationalist view is the idea that certain brain functions reside and live in certain brain areas. And if you remove those brain areas, then the function disappears and is gone forever. And these sort of originated in the late 1800s. Broca published his work in the Broca's area in 1861. Wernicke published his work in the Wernicke's area in 1874. And what they did was they found a patient that Broca found a patient that had expressive aphasia. And when that patient died, when he did an autopsy, and he found that there was a large stroke in the inferior frontal gyrus. And Wernicke similarly found a patient with receptive aphasia. And when that patient died, he did an autopsy and found that there was a stroke in the posterior superior temporal gyrus. So then they created this Wernicke-Geschwinds model of how speech works. And basically, the receptive speech area connects to the expressive speech area via this argument fasciculus. And if you remove any part of these areas, then you have an aphasia. But is that really the entire picture? I mean, if you spend any time with Dr. Komatar, you know that it's possible in some patients to be able to remove the posterior superior temporal gyrus or the inferior frontal gyrus, and the patient may still be able to talk and not have an aphasia. So this can't possibly be the entire picture. And part of the complication with this localizationalist view is that it really arose in the pre-MRI era, and it arose in the pre-direct electrical stimulation era. So when you do a direct electrical stimulation during awake brain surgery, you can create a virtual lesion. You can really be able to localize exactly where different functions are. But we're basically moving away from this localizationalist framework where certain brain functions live permanently in certain brain areas, and we're moving more towards a connectomic or network view of how the brain works. So what are brain networks? So brain networks are areas which coordinate their activities more often than they do with other areas. Brain networks are connected physically by sets of white matter bundles, and most higher level cognitive functions result from within network activity or coordination of networks. So this complicated diagram on the left is a picture of the speech network. So you can see that it's very complicated. It's not just one or two areas, it's multiple areas that are all talking to each other more often than they're talking to other areas of the brain. And arising from this complex interconnectedness emerges a higher level cognitive function of speech. And we're going to dive more into this later. But another way of looking at it is that the brain is probably better modeled as a complex system rather than a complicated system. So, during the 20th century, a lot of people modeled the brain as a computer. Computers are considered complicated systems. They're made of many, many different parts. I probably can't build one in my garage. And we know what every single part of a computer does. If you remove the hard drive of a computer, then the memory of the computer is gone. If you remove the video card of a computer, the screen can't play a video anymore. So while it's a complicated system, it's not a complex system. But I think a much better way to model the brain is as a complex system. So examples of complex systems are the stock market, the economy, the internet. I basically think that the brain is better modeled akin to the stock market. So what is a complex system? Complex system is a large network of interconnected entities which react to each other's activities non-linearly. So just as we have millions of neurons that are reacting to each other in either like on or off, firing or not firing action potential, in the stock market, you have millions and millions of stock traders who are making buying and selling decisions non-linearly in response to each other. So if a stock starts going down, that individual stock picker could either decide to buy a cheaper stock or sell overvalued stock. Complex systems also demonstrate emergent properties that you couldn't necessarily predict going in from the rules that the individual players follow. So examples of this in the stock market include bear market rallies, bull markets, boom bust cycles, things like that. And then finally, complex systems tend to be robust. They're resistant to random deletions. So anytime an individual stock buyer either retires or dies, that is going to barely affect the entire stock market, or perhaps even not affect it at all. And then finally, this is an important property of complex systems. Complex systems display a property called hodotopy. So hodotopy is a terrible word, kind of intimidating and complicated, but it basically means that it's a property that a functional network may contain multiple parallel interconnected sites, but that some parts of the network may be more critical than others. So if you continue with our stock market analogy, so we have different cities which represent hubs of activity of stock market trading. So you might have a more peripheral, less important hub, like, for example, Melbourne, Florida, which is where Christian's from. And if you were to take Melbourne off of the map, it would probably not affect the stock market that much. Maybe the stock market would go down for a day, but whatever stock trading functions were being performed in Melbourne would quickly be transferred somewhere else and easily. In contrast, so New York is probably the major hub of the stock market. I wouldn't say that the stock market lives in New York. If you removed New York from the map, the stock market probably would be pretty damaged for a while and take a while to recover. But I think that if you preserved the telephone lines and the internet and communication, eventually the functions of stock trading in New York would probably be subsumed by other more peripheral hubs that would get promoted to the most important hubs like Chicago and Los Angeles. So similar to New York being the major hub of the stock market, you could say that Wernicke's area might be a major hub of speech. So the speech doesn't necessarily live in Wernicke's area, but it is a hub that organizes activity. So do hubs exist in the brain? Well, different studies have shown when you look at all of the connections of all of the functional areas of the brain, the functional areas that communicate with the other functional areas the most, the ones that are the most interconnected, using DTI imaging, we found that the areas that are the most interconnected tend to be the areas that in the Spetzer-Martin diagram were reported to be the, quote, eloquent areas. So what we in neurosurgery call eloquence, in network theory mathematics, they would call hubness. So eloquent areas are just very interconnected areas that talk to a lot of other parts of the brain. So examples of hubs in the brain include end effectors and primary cortices, like the primary motor cortex, the visual cortex, also association cortices like Broca's area and Wernicke's area, as well as subcortical structures like the thalamus, the basal ganglia, and the basal forebrain. So if the colored areas in this map represent eloquent areas or hubs, what do the gray areas represent? I think a lot of that can be explained as having redundant areas. So, in other parts of the body, we have redundant areas. We have, 2 lungs, we have 2 kidneys. Even though you have these areas of the brain that are not immediately obvious what they do, evolution decided to maintain these areas even though they're very calorically intensive. And that's because having redundancy can be very important, especially when you're responding to injury or tumors or surgical recovery. And this idea becomes clear when if you injure one lobe, that injury is usually pretty well tolerated. However, if you injure both lobes, that is usually very poorly tolerated because your redundancy is removed. So if you have a bifrontal injury, for example, that will often cause akinetic mutism. If you have a bitemporal injury, you often will have no memory. If you have a biparietal injury, you often will have profound spatiotemporal dysfunction. And if you have a bioccipital injury, you'll be blind. So redundancy and reorganization are the glioma patient's friends. So again, the non-eloquent areas are probably providing a great deal of redundancy. And this redundancy can be very helpful in glioma patients. So one idea when a glioma forms is that, as you can see in B, is that the mass of the tumor is pushing the neurons and the white matter connections to the side. So for example, if you have a glioblastoma in the Wernicke's area, that person may still be able to talk. So the question is, how are they able to talk if they have a destructive tumor that's destroying their Wernicke's area? And one thought might be that maybe the tumor is just pushing the functional neurons out of the way. And that may be part of the story, but what I think might actually be going on is that Wernicke's area hub is being destroyed, but as long as the white matter tracts are connecting other areas, then other more peripheral hubs like Melbourne, Florida, might be able to take over the functions of the Wernicke's area. So redundancy and reorganization are the glioma patient's friends if the integrity of white matter tracts linking redundant hubs are preserved. So this is the kind of the most important conceptual slide of my talk, which is that recovery is more likely to happen following surgery if you preserve the integrity of white matter tracts linking redundant hubs. And sometimes after brain tumor surgery, the patient will wake up with a neurological deficit, and we often chalk that up to brain swelling. And that could be brain swelling, although brain swelling usually is a more short-term phenomenon that resolves pretty quickly. I would say like anything beyond a week, that a neurological deficit might more be described as a hub being removed and then the reorganization of the brain via the white matter tracts finding other hubs that take over the roles of the areas that were removed. So, and that's not a bad thing, because if you have a very malignant tumor like a glioblastoma, I think most people would trade a short-term neurological deficit for longer-term survival, as long as the neurological function could be subsumed by other more peripheral hubs that get a promotion to to become major hubs. So now that we have a conceptual understanding of hubs and why the white matter connections are important for recovery following brain tumor surgery, let's talk a little bit about the anatomy of the major white matter tracts in the brain. So I'm going to talk about the anatomy, then I'm going to talk about the networks that perform our higher level cognitive functions and which white matter tracts they perform. And then I'm going to talk about how the white matter tracts are relevant in certain specific brain tumor surgeries to make it more relevant as take-home points. So the major white matter tracts can be divided into, we can make it really simple. We can divide it into the lateral system of white matter tracts, the middle system of white matter tracts, and the medial system of white matter tracts. And you can delve very deep into this topic. You know, people get PhDs in neuroscience and connectomics, and you can learn about every single connection. You know, we have trillions of connections in the brain. I don't think it's important to learn every single connection, but I think it is important to learn the major connections, the major white matter tracts, because these are the ones that really power the recovery or prevent the recovery if they're injured. So all the white matter tracts are basically specified with reference to the cortical spinal tracts here. So the cortical spinal tracts are defined as the middle white matter tracts. So every tract that's lateral to the cortical spinal tracts is part of the lateral white matter tract system, and every white matter tract that's medial to the cortical spinal tracts, everything that's medial, is considered to be part of the medial white matter tract system. And then as a final fourth category of tracts, there are slant tracts, which connect the medial and lateral tracts. Okay, so the important thing from a 20,000-foot view of this is that the lateral white matter tracts all form a wall, and this wall basically blocks safe approaches from lateral to get to deeper structures like the ventricle. So even though often the shortest path through the brain to get to the atrium of the ventricle, for example, is through the lateral posterior temporal lobe, it may be safer to avoid disrupting white matter tracts by picking a more medial trajectory, for example, going to a superior parietal lobule approach. Even though it's a longer trajectory, you're avoiding those lateral white matter tracts that form a wall. So we'll delve into this more in a little bit. But going into the more specific lateral tracts, first we'll start with the superior longitudinal fasciculus, or SLF. The SLF is the most important white matter tract. So if you only need to know one white matter tract, it's the SLF. It actually has 4 layers: SLF 1, 2, 3, and the arcuate fasciculus. So when we say SLF, it's also talking about the arcuate fasciculus. It's very important for phonemic language. So language can be divided into phonemic language, which is the sound of words. So for example, if you make a phonemic error, instead of saying ball, you might say mall or paul. There's also semantic language, which is the definition of words. So instead of saying ball, you might say that round thing, because you don't have the semantic language. So the SLF conveys phonemic language, but it's also involved in almost every important higher level neurocognitive function. So you definitely want to preserve the SLF when you're doing surgery. And the SLF has a frontal ramus, a temporal ramus, and a parietal ramus. So next, and almost equally important white matter tract is the inferior fronto-occipital fasciculus, or IFOF. So the IFOF is important for semantic language, the meaning of words. And the IFOF travels from its frontal ramus through the Lyman insula, all the way back to the occipital lobe posteriorly. And as you can see here, the SLF and the IFOF frame the insula. They travel through the insula and they frame it, and they create an insular window. So it's safe to go through this insular window to get to deeper white matter tract structures and avoid injuring these extremely important white matter tracts. Another lateral tract is the optic radiation. So obviously you see it here exiting from the lateral geniculate nucleus of the thalamus and traveling posteriorly to the occipital lobe. important anatomic relationship is that it frames the lateral aspect of the atrium of the lateral ventricle. Obviously, it's important for vision. Another important lateral tract is the inferior longitudinal fasciculus, or ILF. And the ILF is important for speech and vision. And it's also a common path of spread of gliomas from the lingula of the occipital lobe to the temporal pole. Another important lateral tract is the uncinate fasciculus. So this is a common path of spread of gliomas from the inferior frontal gyrus to the anterior temporal lobe via the limen insula, and it is also important in speech. So those are the lateral tracts. So now moving on to the medial tracts, these are the tracts that are medial to the cortical spinal tracts. So the first important medial tract is the cingulum. So the naming is a little bit confusing. So the cingulum is the white matter tracts that traverse inside of the cingulate gyrus. So the cingulum is the white matter tracts, and the cingulate gyrus is the gyrus in which houses the cingulum. And as you can see here, the cingulum, which is green, travels in a perpendicular fashion to the corpus callosum. So the cingulum travels anterior to posterior. And the cingulum is very important for attention, being able to pay attention to things, your internal state, your thoughts that you think when you're just sort of internally meditating, memory, and emotion. And this is from its well-known role in the Papez circuit. The other important medial tract, of course, is the corpus callosum. So the corpus callosum, most of its fibers connect homologous contralateral brain regions. So there's a so-called rule of fifths of the corpus callosum. So the genu of the corpus callosum connects the two medial prefrontal cortices. The anterior body of the corpus callosum connects the motor and premotor areas of the frontal lobe. The middle body of the corpus callosum connects the parietal lobes, and the posterior body and splenium of the corpus callosum connect the occipital lobes. So our final category of white matter tracts is the aslant tracts, and these aslant tracts connect the lateral white matter tract system with the medial white matter tract system. So the first aslant tract is the frontal aslant tract, or FAT. And the frontal aslant tract connects the supplementary motor area to the premotor cortices, and it's important in SMA syndrome recovery. There's also crossed frontal aslant tract. So this is sort of an exception to the idea that the corpus callosum connects homologous lobes, because here it doesn't. These crossed frontal aslant tract fibers connect the posterior portion of the inferior frontal gyrus to the ipsilateral supplementary motor area and pre-supplementary motor area. And in contrast, the crossed frontal aslant tract fibers connect the frontal aslant tract and contralateral premotor areas through the corpus callosum. So this is from a study done by Michael Shagru, and he found that preservation of the crossed frontal aslant tract fibers enables SMA syndrome recovery. So supplementary motor area syndrome, of course, is a syndrome of operating in the anterior frontal lobe, anterior to the motor strip, and the patient wakes up hemiplegic if it's a right-sided surgery, or hemiplegic and aphasic if it's on the left side of the surgery, and is characterized by an often rapid recovery, although the recovery is not universal. And the idea is that if you preserve the crossed frontal aslant tract fibers, which are in the corpus callosum, meaning if you stay out of the corpus callosum, the patient should recover from the SMA syndrome. However, if you transgress into the corpus callosum and you injure the crossed frontal aslant tract fibers, then you prevent the contralateral size premotor area and supplementary motor area from taking over for the removed or damaged ipsilateral size supplementary motor area and premotor area. So the other aslant tract is the middle longitudinal fasciculus. A better name for it really would be the occipital aslant tract, because it is an aslant tract that connects a lateral system with the medial system, but nonetheless in the literature it's referred to as the middle longitudinal fasciculus. And the middle longitudinal fasciculus connects the upper cuneus of the occipital lobe to the superior temporal gyrus. And it's important for vision as it links the dorsal visual pathway with the semantic areas. So, that was kind of a lot. That's sort of the hardest part of the lecture to learn. But I think if you just remember that all the tracks can be grouped into lateral, medial, and middle tracks, it becomes a lot easier to learn all these tracks. And a lot of these tracks cross in 3 distinct areas. So these are very high-priced real estate areas, meaning that if you do surgery or injure these crossing points, that even a very small injury can cause a very severe amount of damage that may actually not be recoverable. So it can be definitely worth doing surgery in these areas awake if you're going to be doing surgery in these white matter tract crossing point areas. And it's interesting because they also are deep. They tend to be deep to the areas that we traditionally consider to be eloquens, deep to Wernicke's area, deep to Broca's area, et cetera. So the first white matter tract crossing point is the temporoparietal occipital junction, which is at the level of the coronal plane of the posterior insula. It's also lateral to the atrium. So those are the landmarks. And this is a crossing point for the SLF, remember the most important white matter tract, the SLF, the IFOF, the optic radiations, posterior thalamic peduncle, and the posterior limb of the internal capsule. So very high-priced real estate. You can cause a lot of damage from injury in this area. And this sort of corresponds to being deep to Wernicke's area. Next crossing point is deep to the inferior frontal gyrus and middle frontal gyrus, which is in the coronal plane of the anterior insula. And this is a crossing point of the SLF, the IFOF, the frontal slant tract, and the cross frontal slant tract. And this corresponds to the area that's deep to Broca's area. And then finally, we have the medial posterior frontal lobe, which we refer to as the back wall of the frontal lobe during frontal lobectomy surgeries. And this represents a crossing point of the frontal slant tract, the corpus callosum, the cingulum, and the thalamic peduncle. So all of these tracts, basically, you start to see them at the level of the depth of this of the bottom of the sulcus. So superficial to the sulcus, you just have the more superficial U fibers, which are less important. Those are just more for local connections. Once you get to the depth of the sulcus, that's when you need to start thinking about or mapping or worrying about the more important white matter tracts and their crossing points. So now we're going to move on to the major networks of higher cognitive function. So remember, higher cognitive function requires multiple networks that are firing or multiple brain areas that are firing together, being connected by important white matter tracts. So we're going to talk about the major networks of higher cognitive function, as well as their underlying white matter tracts that connect them. So the first network is the motor network. Obviously this involves moving arms and legs and the face. The major white matter tracts underlying the motor network are the cortical spinal tracts, but also which is obvious, but also the corticocerebellar tracts, the cortical bulbar tract, the thalamic peduncles, and the frontal slant tract. And I'm showing this picture not to learn every single voxel of the motor system, but just to show that the motor system is much more than just the motor cortex. It also involves all the planning areas and coordinating areas for the motor system. And it's a much more involved and complicated system than you might think as just the motor strip and the cortical spinal tracts. So for this reason, I think it's reasonable, and in my opinion, you should consider always doing motor mapping awake instead of asleep. People might disagree with that, but that's my opinion. And the reason for that is that the asleep motor mapping methods are very good at finding the motor strip and the underlying cortical spinal tracts. However, if all you have is a disconnected motor strip connected to the spinal cord by the cortical spinal tracts, it won't drive the anterior horn cells. You'll have a moving but functionally useless hand or arm or leg or whatever, which is only slightly better than a plegic one. So for this reason, my recommendation would be to do motor mapping awake when feasible. So moving on to the speech network, we don't need to learn every single detail here, but just to show that there's a lot of important white matter tracts underlying the speech network. So we have the SLF, which includes the arcuate fasciculus, as I mentioned. We have the IFOF, the inferior longitudinal fasciculus, the frontal slant tract, and the uncinate fasciculus. So the other important aspect of the benefit of this system being very complex is that speech is involved with many other networks as well. So when you're mapping for speech, you're actually also often mapping for many other networks. We'll discuss that in more detail in a few slides. So next, moving on to the visual system. So obviously, the optic radiations are important for early visual processing, visual information processing. But this complicated picture to the left shows that a surprising amount of our brain is dedicated to higher level visual processing. And this higher level visual processing is underlined by white matter connections involving the middle longitudinal fasciculus, the inferior fronto-occipital fasciculus, the IFOF, the ILF, and the SLF. Next is the praxis network. So the praxis network underlies the ability to execute or carry out skilled movement and gestures, which is separate from the physical ability and desire to perform them. So this isn't just being able to move your arm, it's being able to move your arm in a very specific way, like, for example, to be able to tie a knot or put on your clothes or button buttons, tie shoelaces, things like that. So the praxis network is a localized area. It's a left-sided network. So the underlying white matter tract is the left SLF. And interestingly, in most cases, saving speech means saving praxis, as the networks are so tightly linked. So while you can do higher level testing of higher level functions, you can do a pegboard test where you take pegs and put the pegboards and take the pegs and put them into the pegboard. Often, if you're testing speech, you're also testing praxis. The next network is the neglect network. A better name for it might be the spatiotemporal network, as it processes our ability to understand where things are in space and time, including our extremities. It's right-sided dominant. So it is a bilateral network, but it's dominant on the right side. So that's why if you have a right-sided parietal lobe injury, you get neglect. So the left parietal lobe is not able to compensate for the right side. So both SLFs, left and right, are involved in the neglect network, but it's a right-sided dominant network. Next is the attention networks. We have two. We have the dorsal attention network and the ventral attention network. Obviously, they're our ability to concentrate and focus on something, and these are underlined by the SLF. You're probably noticing a pattern, which is that almost all of these higher level functions are underlined by the white matter tract of the SLF. As I mentioned, it's the most important tract. And then finally, we'll talk about the control networks. So these are the top of the hierarchy of the telencephalon, and they're the axis around which all of the other networks align. So they include the default mode network, the DMN, the central executive network, the CEN, and the salience network. And in normal healthy patients, you can either have only the central executive network active or the default mode network active. You don't have both active at the same time. It's either one or the other. Interestingly, in many psychiatric diseases, you do have both active at the same time or neither active at the same time. But having one or the other active at one time is what's found in healthy people. So the central executive network is our ability to focus on external goals, executing external goals, whereas the default mode network is our ability to have an internal mental state, contemplate, plan while we're focusing inward. In the salience network, switches back and forth between the default mode network and the central executive network. So again, these three networks basically are the central axis on which all the other networks align. And the default mode network, the major white matter tract underlying it, is the anterior and posterior cingulum. The salience network, the major white matter tract underlying it, is the middle cingulum and the frontal aslant tract. In the central executive network, the major white matter tract underlying it is the SLF. So as you can see here, the default mode network, the salience network, and the supplementary motor area together form a strip, which has been called the initiation axis. The initiation axis is required to go from an internal goal to execute an external plan. And when you have damage to the initiation axis, you get really terrible consequences like abulia, akinetic mutism, and supplementary motor area syndrome. And these are some of the types of patients that Dr. Harris might refer to as patients that can walk and talk, but they'll never be the same. They may be able to move all four and answer questions, but they're sort of shells of their former personhood. So here's a summary of all of the important higher level cognitive function networks, as well as their underlying important white matter tracks. And just a few take home points. As I mentioned, the SLF is important for almost all of them, involved in almost all of them. So it's clearly very important to try to preserve it. The other observation here is that there is a great deal of overlap of different white matter tracks in different higher cognitive level functions. And, you know, the reason I think this is interesting is because when Hugh Defoe came, he's very famous for doing awake brain tumor surgery, particularly in low-grade gliomas. And when he operates in France on awake patients, he has this whole team of neuropsychologists. They're doing all these very complicated advanced neuropsych testing just about every single function under the sun. And when he came, I was wondering to myself, are we shortchanging patients here? Are we not doing all the testing that we need to be doing during awake brain tumor surgery? But I was also kind of confused because I happened to notice that all of our patients, or almost all of our patients, did extremely well following surgery. So how could that be? And doing the research for this talk made me understand that I think that simple awake testing is usually fine because there's so much overlap among networks. So for example, when you're testing someone's language, you're also testing their praxis and their visual networks and their neglect networks. There really is a lot of overlap between these higher level cognitive functions. So, there's always a trade-off in the operating room between being able to test every single function, but also efficiency and length of surgery, more exposure to anesthetic agents, and that everyone's trade-off might be different, but having an efficient, simple test that's able to test multiple different systems is probably a good thing to have. So now we're going to move on to applied macroconnectomics, basically how all these white matter tracks and networks kind of play a role and when to look out for them in different brain tumor surgeries. And the idea here, just to spell it out, is that when you have a glioblastoma, the enhancing part of the tumor is not the only part of the tumor. We know that there's tumor cells that are extend far beyond just the enhancing edge of the tumor. So the question is, how do you know where to operate and where to stop operating? And there's two answers. There's, anatomic boundaries like the falx, the dura of the floor of the middle fossa. These are hard stops that you can't continue resecting brain because there's no more brain left. But then there's also, neurophysiological or neurofunctional areas where you need to stop your resection in order to preserve someone's neurological function. So having an understanding of the connectomics helps you understand how aggressive you can be while safely preserving function. So here we have, for the frontal lobe, the major white matter tracts tend to be in the posterior area. So we call this the posterior wall of the frontal lobe. And the posterior wall of the frontal lobe is formed from the frontal rami of the SLF, the IFOF, the cingulum, and the frontal aslant tracts. Of course, other limits which are in the same region are the caudate and the putamen. So this helps you stay out of the basal ganglia as well. Here's another picture of the posterior wall, the back wall of the frontal lobe. Essentially, if you stay to the level of the anterior part of the frontal horn of the lateral ventricle, that sort of corresponds to where these white matter tracts start. And I, of course, need to make the caveat that this is the anatomy in a normal person's brain. In a patient with a glioblastoma or brain tumor's brain, the shape of their brain and their wiring may be markedly different. So you may need to look at preoperative DTI to understand this. You may need to do awake brain tumor surgery mapping in order to understand any changes in position of these white matter tracts. So I'm talking about the anatomy in a normal person, but that anatomy may be extremely different in an actual brain tumor patient. So when in doubt, always do your brain tumor surgery awake. Next, moving on to the temporal lobe. So you can divide the temporal lobe white matter tracts into a lateral system, an inferior system, and a medial system. So the lateral system, which comes into play in the posterior part of the temporal lobe, so not the anterior part, but the posterior part of the anterior lobe, the part that overlies the posterior temporal horn of the lateral ventricle and the atrium of the lateral ventricle. And this contains the SLF, the IFOF, and the optic radiations. And this is the part that blocks access from the lateral approach to the deeper the deeper structures. There's also the inferior part, the inferior system of the temporal lobe, which involves the ILF. And then finally, there's the medial system, which includes the hippocampus, the fornices, and the cingulum. And the idea here is that you're able to resect one or more of these white matter tract systems while preserving the other white matter tract systems if needed. So, the danger points here for temporal lobe surgery are posterior. So if you go far posteriorly, eventually you'll get to the temporal rami of the SLF and the IFOF, and the optic radiations, of course. Again, this is sort of in the region of the posterior temporal horn of the lateral ventricle and the atrium. And then also deep, you need to be careful with your depth of resection. So if you continue through the temporal stem above the ventricle, then there's no Peel plane that'll stop you from getting into the basal ganglia and the cortical spinal tracts. So one thing to do when you're doing a temporal lobectomy, for example, is if you preserve the hippocampus until the end of the surgery, as long as this acts as a depth gauge, the hippocampus acts as a depth gauge. So if you stay lateral to the hippocampus, you know that you'll be lateral to the cortical spinal tracts and the basal ganglia. Next is the parietal lobe. So there's two major parts of the parietal lobe. There's the superior parietal lobule, which it doesn't do a whole lot, for lack of a better term. This is why superior parietal lobule approaches to deeper brain structures are relatively well tolerated, or extremely well tolerated, I should say, in the inferior parietal lobule. And the inferior parietal lobule is basically the supramarginal gyrus and the angular gyrus. And interestingly, the supramarginal gyrus and angular gyrus are only found in human beings. So other animals, even chimpanzees, don't have a supramarginal gyrus or an angular gyrus, and this underlies, the importance of these areas in higher level cognitive brain functions. In addition to the so when you're doing a superior parietal lobule surgery, the important thing is to stay posterior to the sensory strip and the motor strip, and you want to stay medial to the temporal occipital parietal junction, which I'll talk about in a second. But it's a relatively well tolerated area to operate. However, the lateral parietal lobe is a very treacherous place to operate, and I think it's very reasonable to do a surgery in this area awake, because this is a major crossing point, as I mentioned, for many tracts, including the middle longitudinal fasciculus, the optic radiations, the arcuate fasciculus, the SLF, the IFOF, the ILF, and the posterior limb of the internal capsule. So this is a very high-priced real estate region, and you need to be very careful here. And Yastrugol actually had a quote, which is that AVMs of the parietal lobe were some of the most treacherous, and he was clearly ahead of his time with that observation. Moving on to occipital lobe surgery. So a lot of patients that present with a glioblastoma of the occipital lobe usually present with a homonymous hemianopsia, so very challenging to preserve visual function in these areas. So the reason I'm bringing up occipital lobe surgery is that it's very common for occipital glioblastomas to extend medially into the temporal lobe through the middle longitudinal fasciculus, and it is safe to follow this tumor into the medial temporal lobe, and you can remove that while preserving the lateral system of the temporal lobe, and then you're preserving the lateral system, including the IFOF and the SLF. So next, moving on to insular surgery. So, insular surgery is very confusing for people at the beginning. The anatomy is relatively complicated, but here you can see it is a cortex that is roughly in the shape of a right triangle, and it's completely covered by operculum. So there's a frontal operculum, the inferior frontal gyrus, and a temporal operculum, the superior temporal gyrus. So in order to be able to see the insula, you have to either do a trans-sylvian approach, where you split the sylvian fissure, or a transcortical approach, where you remove one or both of the operculum covering the insula. So how do you decide which approach to do? So a trans-sylvian approach is reasonable. The limitation to a trans-sylvian approach is that it's difficult to create enough exposure to be able to easily map and put an Ogeman simulator and map the SLF and the IFOF. So that's one challenge of doing a trans-sylvian approach to the insula. Another issue is that it's relatively rare to have a purely insular glioma. A lot of insular gliomas also extend into the frontal lobe or the temporal lobe. So if it does extend, for example, into the temporal lobe, I think it's very reasonable to do a transcortical, transtemporal approach to the insula. You remove the temporal opercula, and then you're able to see the insula. As you can see here, as I mentioned before, the IFOF and the SLF frame the insula and create an insular window. So if you wanted to, you could actually map these out. Speech is probably the easiest to make sure that you're not transgressing these important white matter tracts. So after you have the insula exposed, you create windows in between the branches of the MCA, and you take out the tumor in the insula. And then, one question people always have is, how deep do you go with insular surgery? So another benefit of doing a temporal lobectomy or a transtemporal approach to the insula is that if you preserve the hippocampus, this can act as a depth gauge, because the lateral aspect of the hippocampus roughly corresponds to the lateral aspect of the putamen. So if you stay lateral to the hippocampus, in that parasagittal plane, you'll stay lateral to the putamen. Obviously, if you see something that looks like nutmeg, you're probably in the basal ganglia, but it's often better to prevent getting into the basal ganglia rather than realizing that you're already in it. We'll skip that for time. Corpus callosum gliomas. So these are obviously very challenging to treat. You can do open surgery. Our center has published very good results with doing bilateral laser interstitial thermal therapy for treatment of butterfly gliomas. The important point here is that when you're doing cytoreduction for these tumors, you want to try to preserve the cingulum, because obviously the cingulum is very important, and particularly a bilateral cingulum injury can be very devastating. And then finally, for thalamic gliomas, so thalamic glioma is also very challenging to operate in without causing a permanent neurological injury. One of the reasons for this is because of the thalamus basically has projections to the entire telencephalon, so very, very high priced real estate. But one way to make it more safe, either by doing an open surgical resection or doing a laser interstitial thermal therapy catheter placement, is to avoid lateral approaches to the thalamus. That in those lateral approaches, as I keep saying, go through the lateral white matter tracts. So you can either take an approach that doesn't transgress brain, like a non-transcortical approach, like supracerebellar, infratentorial, or interhemispheric, or if you're going to go transcortical, you could do a superior parietal lobule approach, going through the medial aspect of the parietal lobe to get to the thalamus. So in conclusion, maintaining the integrity of white matter tracts, linking redundant. It's important to maintain the integrity of white matter tracts that are linking redundant hubs, because if you're removing hubs along with tumor, then those redundant hubs will then take over as the actual effectors of different brain tumor, cognitive brain functions. Glioma patient brain is not the same as the normal brain. So for this reason, when in doubt, you should do brain surgery awake. DTI is your friend. Learn to use it, can be helpful in preoperative planning. And then every neurosurgeon, at least every neurosurgeon operating on the brain, should become a connectome expert. And then finally, I would like to say thank you to Dr. Edward Overfield and Mary Ann Overfield for funding my INOS trip to Australia, which is how I kind of got plugged into all this connectomic stuff. Thank you to Dr. Mike Charoux for teaching me a lot of these concepts, Dr. Charlie Teo for hosting me, Dr. Komentar and Dr. Ivan for facilitating my INOS trip, and Dr. Hugh Defoe, when he came as a visiting professor, I learned a lot about connectomics from him. So thank you.
Hey, Dan, that was amazing, and congrats. I'm looking forward to publication of the For Dummies book, part 1, I guess, coming out in TEM. I guess, and the great thing about these For Dummies series that you're going to publish, there's always room for part 2 books. You sort of alluded to it a little bit, but the whole process of recovery, it can either be edema, retraction, or true recovery and reorganization. And we see this a lot in spinal cord injury patients who actually recover 15 months after their injury because of reorganization. I just think it's super challenging in this subset of patients because of the issues of age, which you didn't really talk about, but obviously a lot of these patients are older and their ability to reorganize is poorer. And then the other part of it too is that as opposed to a patient with a spinal cord injury, these patients are then undergoing chemo and radiation therapy, other things that will injure their brain and prevent things like reorganization. So it's more like a comment, I guess, than a question, but how important do you think that is in the whole recovery process? Age and radiation.
I mean, all extremely good points. I mean, obviously, recovery is worse in older people. Chemotherapy and radiation are actually injuring the brain, just like you said. I don't know if we have a great answer. I think we're only now starting to get the tools to be able to kind of parse that out and get a better understanding. So hopefully, in the coming months or years, we'll have better answers.
Yeah, just to add on there to that comment, Dan, is that in the patients that we have been looking at their connectomics pre and post-op, that question is still remains quite elusive because the artifact from a post-operative case and then the edema kind of disrupts the connectome on imaging, so that it's hard to know if it's really preserved or not preserved within that early post-op kind of 48-hour window, which is when we really want to know what's going on. But I would say excellent talk. We're super proud of you. This is a great analogies that you used, and I too am excited for the book to come out. That'd be awesome. Great job.
Thank you,
Dr. Dietrich.
Okay, thank you, Alan, and Daniel. Thank you very much for that very, very informative talk. I think the talk today by Dr. Pontelis Sofas, who's associate professor in the Department of Neurological Surgery, is very relevant to what you just heard in terms of a better understanding of the three-dimensional reconstruction of the circuits going up and down the neuroaxis. And Pontelis is a pioneer in 3D imaging in the country, and works with many individuals throughout the United States. And today he's going to talk a little bit about utilizing his 3D imaging approaches to study supraspinal connectome, which was mentioned today, in terms of what important circuits are being injured after spinal cord injury, what's their normal function, and how we can target these circuits to enhance functional recovery. Pontelis, good morning. Thank you very much for being here.
Good morning. Good morning. Yes. So it's interesting, listening to Daniel. So this is a kind of similar ideas, but in a much smaller brain, like the mouse brain or the rat brain, which probably will cover just a small area of equivalent of the human brain. So our scales are much smaller, but still really challenging in various ways because of the complexity of the nervous system, millions of neurons connecting in all kinds of interesting ways. So, be able to know all these connections and what they do and study them, will have great advantages, not just from basic knowledge, but especially in clinic. Now, let's go through the acknowledgements. This work is really a collaborative work, like everything is done in science these days. I'm not trying to take credit for all the work. A lot of this work has been done in collaboration with Murray Blackmore and his team at Marquette University. It has been really a joy working with Murray. There are other people like Benjamin Campbell at Gregory Petzker Cornell University that we got some probes from him. In Miami, my assistant, Yun Fang, a lot of things have been done without her. And then others, there is a lot of people here in this building that contribute in intangible ways and are not taking as much credit. And that is the viral core, the microscope core, the bioinformatics core. Without their help, we can't really do anything. And then, listening to Daniel, he's part of this community of knowledge. He feels the vast majority of the details of our knowledge and every of us understanding as a scientist. So without all of the people out there and who has first come, we won't be talking today. And I will start with the first guy, Turk Ludwig. Maybe a few of you guys know it. He's the first guy to describe a tract, the anterior corticospinal tract or the tract of Turk. Probably you neurosurgeons know more about it. So this story of tracts goes really back, even before Cajal or Golgi, and everybody starts with Cajal, somehow forgetting all these other people before him. And then in medicine, I see guys, you have all kinds of conflicts of interest because you consult for companies and so on. I don't have as many. My conflicts of interest are mainly my biases. And listening to Daniel today and others, definitely I know nothing except the fact of my ignorance, and that is true. And then I'm not an expert because I didn't make all the mistakes on my very narrow field. You as neurosurgeons, you cannot make mistakes. So that means you're experts. Now, so maybe, Daniel, I lost the first 5 minutes of your talk, so I don't know how much you went into this connectomic approach. Actually, this is a relatively new concept. The term was coined maybe a decade back by Sporn, and there are 3 levels of connectomics. The ones Daniel's talked today is the macroconnectomics. I'm going to talk a little bit more about the mesoconnectomics, which is really at the cellular level. There's a fine line between these two, and then the microconnectomics, which practically trying to understand each connection of the very fine detail. And that actually has been attempted in C. elegans and has been completed in now also other organisms. Now, why we undertook this project, definitely there is the distribution, as Daniel saw you, is complex and wide. There are dozens of brain projecting populations everywhere. The anatomical arrangements in an entirety is difficult even to conceptualize. Practically, you can't even remember them and knowing them. And Daniel said, you don't need to know the details, you need to know them. Maybe that is correct, when you go into surgery, but for us, we do want to know the details. Now there is a convergent intermingling of these descendant spinal tracts. And how it's difficult to parse the different functions by selective ablation, or even after injury. And then the nature of the descending control is really interactive. It's not a single population. I know a lot of people focus on the corticospinal, but there is more to that. And then obviously resolving the variability, especially in spinal cord injury models. Now, part of this why I undertook this project, if you look what people study, at least in animals, is they always focus on, and this is a search we did. This is the number of publications over the years. And if you really look what people study, is mostly dominated with the corticospinal tract, red nucleus. In humans, not as important perhaps. Raphe, reticular formation, and the vestibular. Now, this is just few names of the tracts that go to the spinal cord that we know there is a lot more, and they barely get mentioned. And a lot of them have important functions. The pedunculopontine is emerging right now, parabrachial in pain, cerebrospinal, and the list can go on and on and on. So that is a limiting factor. So we wanted to just look at the entirety. Now, we started this project using whole brain fluorescent microscopy of the supraspinal neurons, and the reason we did that is for a few things. Is we wanted to standardize. Everybody does his own methods, so if we could get some common ground how to do it, it would be great. Democratized by that means sharing the tools and knowledge, and perhaps helping others. Definitely the reproducibility issue, what methods we can use. I know we have our biases, and a lot of reproducibility is not as much as the methods and maybe interpretations. And then the last is educating people about these connections. Here is on the list of the various methods we use, and I will go through each one of them. First one is the use of viruses. These days, it's not just in clinic, but it is widespread in every aspect of basic research, especially working in animals, because you have to deliver genes. It's not so easy. Viruses are amazing on delivering these genes. And in this project, we use the adeno-associated virus. Has been discovered back in 1965. This is a small virus that is not pathogenic. Most of us have been infected with some kind of serotype and needs the adenovirus 5 to replicate. This virus enters through the typical endosomal pathway into a cell by binding a specific receptor that gives them specificity, the tropism of the various viruses. And then the virus gets uncoated and the DNA remains episomal, which means doesn't integrate into the genome. And that could have this one advantages. For example, it's not subject to silencing and so on. And this virus cannot self-replicate unless you provide some of the proteins. Now, in humans, there is, I think, 12 serotypes, maybe 14, is unclear. And each this serotype has a particular tropism, and has been a lot of work in the last, but it's going a long time, but in the last 5 years has been exploded. There are companies and so on. And what they're trying to do is practically change one of the particular genes, the CAP gene, the envelope, to confer different specificities, practically select the type of cells and so on. And here are a few of the methods that have been used for a long time. But the one virus we really are focused in this case is a synthetic capsid, and it's called the AAV2 retro. And because most of the AAVs are anterogradally transported, so they go forward through the axon. In this case, this capsid has the ability to retrogradely transport it. And so that means if you inject in the spinal cord, then axons that project to that particular segment will take the virus and be transported all the way back to the brain. And that is, for example, one case. This is a different serotype, a paper published recently by the lab of Dr. Chowdhury, and I participated to this. This is a selective virus that infects only peripheral neurons and not central. So that gives people like Nirupa the ability to study taste, which is difficult to access the geniculate or any other targets. The second part is we use a lot of these fluorescent proteins. There are too many, but the one we wanted to use is to be really bright for all kinds of reasons, but mainly optical. So to make sure the light exits the tissue and can be detected by a microscope. The other thing we did, which I will explain down, is we wanted to target this fluorescent protein to the nucleus for all kinds of reasons, and mainly is really to count and identifying the cells. And here is some of the versions we use. So we really focus mainly on practically a gene we made synthetically, where you fuse the protein H2B, is a histone that usually localized to the nucleus, with the fluorescent protein. So if that protein gets expressed, it will go only into the nucleus. So then you can identify just that particular cell. The next thing we use is the clearing. This is an old technology, goes back in 98. The patent is in 908. The article was in 1913, and this is by Vernon Spalterholz, German anatomist. Maybe a few of you guys know about his work, and is able to clear entire arms. using some chemicals. And the pattern here, I just read the pattern. With the methods commonly used for the production of microscopic preparations, it was not possible to make the construction of organized bodies sufficiently accessible for observations. You guys have MRI. We don't, we have MRI, but it's not as widely used. By cutting into sections, many parts are destroyed and the connections between the parts is broken. Cutting up into sections promotes the recognition of details, but prevents the recognition of the overall arrangement. The second important aspect to that clearing is using the right microscope. We use the light sheet. The light sheet here shows you that practically the light is perpendicular to the objective, where conventional objectives are in the same axis. So you have a sheet that goes across the whole tissue, and then you collect the simultaneous the whole point. That is, again, it's an old technology. This was, I won't go into the details, for studying colloidal golds back in 1913. In fact, Zygmundi got the Nobel Prize on this. And you could call it ultra microscope, but really the inventor of the microscope was Henry Sinderthrop in Zeiss back then. So that is the old instrument. It's not a fluorescence. Now, there are all kinds of new versions, and we have actually two here, the Miami project. And so if anybody's interested, let me know. We can help them with that. Now, okay, you have all this data, so you are acquiring all the images. How do we know where the cells are in the brain? Daniel shows all these connections, but there are cell bodies somewhere, and you guys can say, okay, comes from the Broca area or Wernicke and so on. In mouse, we're not neuroanatomists, so we need really help to identify the cells within the whole brain. Now, there is a lot of methods these days of image registration and segmentation in animals. Actually, now they have been expanded also to primates, rats. And in our case, we use the Brain Globe or Cell Finder, and you will see and explain this a little bit better. This is just a computational method to take our data and register into an atlas. A mouse brain can tell us where they come from. The Brain Globe initiative is a European initiative run out of the University College of London, and there are several parts of these. There is the registration, then there is the Cell Finder, which is really harnessing a deep learning algorithm to count automatically your cells, so you can get quantitative data, and then Brain Render to visualize the data in 3D. And NAPAR is just a multidimensional image viewer for Python developed by the Mark Zuckerberg initiative in microscopy. Now, okay, so if we put all this together, this is on the nuclear, and we clear a brain. So in this case, we injected a virus in the cervical spinal cord. It's expressing a fluorescent protein that we will express in the bodies and the axons. And so you can see not just where the cells are located in the brain, but also their projections. Then we clear it, and with the methods, the modern methods, but pioneered by Spanderholz, and then using the light sheet, acquiring the images, then taking the images into putting into the software. And here is the brain of the mouse. So what you see here is the cortical area, motor area, sensory area, red nucleus. You can see the axons, and soon you will see also the collaterals. Daniel talked about the corticospinal tract and where they go. So there are, at least 10, 20 different collaterals that go as a corticospinal tract is connected. Remember, these are the ones that go only the spinal cord. In mouse, we know only 30% of the motor cortex neurons go to the spinal cord. The rest, the 70%, most of them reach the bulbar area and other areas. So what you are seeing is only the 30%, because the virus was injected in the cervical cord. So I want just to go back to show you the collaterals. So, and you can see the tracks as they go, like in this case, here is the pyramidal decussation. This is the red nucleus. And here you see some of the projections to the tectum. And here is to the putamen. And if we go more deep, we can see even more of these collaterals going through the brain. So now we have the ability not only to label them, but also to track them. Now, the question, so in that image, what you really saw is you saw practically a forest. We don't just want to show pretty images, we want to quantify the data. So if you have an injury and then you want to see what is spared by using a virus which is injected after the injury, how many neurons are still connecting and where they are, these neurons. If we use the first methods, the version 1, will be really hard for us to get quantitative data. We're just going to be guessing. So what we did is we devised this, is not our invention, people using nuclear localized proteins for a long time. And so we did this side-by-side comparison, and we tried to quantify where we were able to quantify the cytoplasmics versus nuclear. And here is some of the numbers here on the right, and they can tell you that if you use a nuclear localization signal, you can detect more neurons. That means there was some intrinsic artifact in our first methods that, using a cytoplasmic protein, you could not detect using this type of microscope. It doesn't mean it's not expressed. We could not detect all the neurons. So now, so the nuclear gives us the possibility to do that, and you can see a difference here, cytoplasmic in the medulla area. You can see where the corticospinal tract is crossing. Here is the reticular formation of pons, but using the nuclear protein now, you can see the reticular formation of the medulla or even the red nucleus. So that gives us a lot more detail. Now, so what we do is, we take these, here's our pipeline. We inject the virus at different parts of the spinal cord. We let it retrogradally transport it, and then 2, 3, or 4 weeks later, we take out the brains, we clear them, we go into the light sheet, then we render it into this software, then we export all the images. I have to say, these are 500 images, not as many, compared to the human, is just nothing. But anyway, for us, it's really a lot. We take these planes, and then we use this software through a particular pipeline, which you register and you cell detect. Then you get back a spreadsheet, or you get images in an Excel file. This registration is done into the Allen Atlas mouse Allen Atlas. To date, at least the consensus is not really the absolute truth. There are 690 different regions in the mouse. Each one has a name. So this software practically will register your dots into each area outlined here. You can see this is just one 2D image. You take the image. This is a kind of rendering it, the dots into this registration. And number 12, for example, is the intermediate reticular nucleus, the 37, the baryton nucleus, which is the nicturition center. And we can go on and on with all the nuclei. We don't have to do that now. So then so the software tells us where these neurons are. Gets out these Excel spreadsheet of 69 nucleus and tells you how many in each of these nucleus is. And here we just put them in a kind of a graphic mode as an output. And then with the brain render, we, like you guys have, with Daniel show some of these schemes of projections, then we can have something similar where our neurons are within the mouse brain. Now, So we did the study. We did both thoracic injections, lumbar injections, cervical injections. We analyzed up to 40 brains, but we cleared 150 brains to go through this whole project. We accumulated close to 30 terabytes of data, and which was a challenge per se to actually store them. But anyway, we went through all these using these pipelines, and we got out of the list 69 regions. So we found that if we inject the AV2, we can identify reliably 69 regions in the mouse. And here are the names, are all tongue-twisting names with Latin and Greek names, which makes it a little bit difficult. So what we did here for us, so now you have, as Daniel says, do you really need all the information? In our case, yes, we do really need it, but now our brain can synthesize it. That is a challenge. So what we did here, we just pare them down, we cluster them based on functions and vicinity into 26 regions. And here is some of the numbers. So here is L3 injection, L1, T7. Here is the spinal cord injections. Here how they look. The brain is looking from a dorsal view. Here is our summary regions, and here are all the numbers we can detect. How many neurons of the trigeminal project down to, let's say, L3 or 4, or versus L1 versus T10. And here is just a schematic. The number signifies a neuron. These are the hypothalamic, medial, and lateral zones, and looking where the neurons are exactly in which nucleus. So if we compare the T10 to L3-4, the number of neurons is quite similar, maybe with the exception on the thoracic we have two, the lateral reticular and the gigantocellular reticular nucleus, to be slightly reduced. And that, could make sense, doesn't have as many muscles to move, and so on. Now, we did that also at the cervical, and here are some of the comparison on cervical lumbar projected supraspinal neurons. I want to make a qualification on this study. This virus does not label 100% all the supraspinal neurons. There are some nuclei that are refractory, practically cannot take up this virus, and probably that is due to the expression of the receptor that the virus binds. We know, for example, that the Rafa formation, we can label some of the medial, but not the lateral as much. The other thing this virus does, as to qualify, is detects excitatory neurons in majority, does not detect, that is not taken by inhibitory neurons. We know there are inhibitory projections to the spinal cord. Those are not labeled. There is a small fraction. So just to make sure, what I'm talking to you is maybe hard to put a number, but it's not 100%, maybe 80, 90% of the projections. So here we did a direct comparison between cervical and lumbar. We got the numbers, we plotted it here, and here is a lumbar projection index, practically tell us, what is the percent of the lumbar neurons versus the cervical. Obviously, the cervical has more projections, and this is evident in some of the since it's a lumbar, so okay, let me go back. The bigger the bar here is, means there is more lumbar. So turns out that few areas in the brain have more projections to the lumbar than to the cervical. And one which is really interesting is the hypothalamic area. So the hypothalamic area has a lot more neurons projected to the lumbar than to the cervical. And that might be has to do with the autonomic nervous system, so other functions. Another one that was interesting, at least for us, is the nicturition area, practically the some of these areas will control the bladder, and so on. So we can get numbers between cervical. So that is really useful, not just from a neurological point of view, but also after injury. Now, this is telling we're counting neurons that project to these different areas. Now, it doesn't tell us about collateralization. So it doesn't tell us whether a neuron projects both to the cervical and to the lumbar. Our pipeline wasn't able to, is not really designed to do that. So, then we wanted to know how many of these neurons project to both areas, and that has important functional implications. And what we did is we used a slightly different method. And this wasn't as sophisticated, the pipeline, as the previous one. So what we did here is just a movie to show you. What we did is we inject AV2 retro, one color, AV retro to another color, C5L4. Then we take the mouse brain, we section it in 2 millimeter transverse sections. Then what we do is a year and a half ago, we got this amazing confocal. It's really fast. Practically, we can scan these whole mouse brain sections overnight. So we can line them up on the microscope, tell the microscope, take it. And so now what you see is all these sections with starting at the more caudal section of the brainstem. Here is the cerebral spinal, shows you red versus green. Red is projecting to the cervical, green is projecting to the lumbar, and then it's going to show you the red nucleus. And then with the software we can determine how many of these neurons have both colors, which is really telling us that this particular neuron projects to both areas. And so now we can get a percent of the neurons that project in both areas. So the data we're going to show you is on the quantification. I'm just let it play to the end, and here are just the dots the software is putting in yellow, tells you which ones are colocalized. And so here is again, we show the colocalization index. So for here is our control. Cortical spinal tract, there is at least with our method, we get approximately 50%. So 50% of the neurons will project on both areas. But if we look at the cerebral spinal, it's only 8%. Red nucleus was known for some time. It's only around 15%. And here is some of the other nuclei, how much they collateralize. So we have these numbers now. This was a study that we published. So the data are really available. One thing I wanted to do is, in terms of education, let me exit and I will get back. So hopefully it doesn't crash the computer. So in terms of education, what we wanted to do is we wanted to spread this knowledge a little bit. Obviously, the numbers, the data were very large. We put it on the paper. So we created a website that it goes with it. And practically, we call Exploring Nuclei of Descending Input to the Spinal Cord. And here practically shows the representative brains. This is just the brain rendering that we use. And practically you can, let's say, go to the cervical lumbar region, it gives you 2 brains. Then you can go to the visualization. I won't load the interactive because my computer is not really fast, but you can interact with the data on the brain, so you can zoom in and highlight the areas you want. Let's see. Here we show few of the sections, not all the sections. You can navigate them, and here are there is a kind of index that shows, the number and which way the nucleus, and I won't go down here. There is a drop bar that you can go and look at your, at the numbers. So check it out. Froze. Oh, no, that's great. That's great. Sorry, get back to the presentation. Here, so anyway, if you are really interested, let me know. And here is the website. Let me put it here, 3D Brain, and here is the address. And here's a lot of interesting information for everybody to look at it. Now, in terms of the spinal cord injury, so okay, this is really nice neuroanatomical study. A lot of these projections were known for over 100 years. Some of the numbers, what is new here is just looking at globally and getting some actually numbers of collateralization and so on. So more quantitative, more comprehensive. But the basic knowledge was already here. So we are not, it's kind of not reinventing, but there is also some new information. For example, there are a few projections that were really unknown. We never found any references about these projections, especially from the Olivary complex. There were some surprising for us because we're not a neuroanatomist. For example, central amygdala projections to the spinal cord and so on. So at least now you have, you can look at all these projections. Now, let's see how we can leverage this to the spinal cord injury, to study variability, to study recovery after injury, after intervention. So you would like to know after a regenerative strategy, whether neurons have really regenerated and from which areas are regenerating. And so then you can correlate to the behavior and so on. So this is like the first pass we did. It's not as comprehensive as the first part, but here is just a hypothetical. So you do the retrograde labeling from the lumbar region. That is your pre-injury connectome or mesoconnectome. And the average number then is defined by 100. Now, if you have an injury, not all the areas will project. And depending on the severity of the injury, certain areas will be spared, some others will be more affected. And so this is a hypothetical post-injury connectome. So what we did here is took the same approach. So we performed spinal cord injuries. This is not the classical drop injury. This is a compression injury using forceps. So you can use different force, lateral force, or distance between the two pieces of the forceps, and we have it as mild, moderate, and severe. Here's the spinal cord and how it looks after those injuries. And as you will expect, this is a severe, very few neurons remain. So then after the injury, we wait for 2 weeks. We inject the virus below the injury, and then we run the pipeline and look at the then we count, and here are represented areas that have some of the labeling. The severe doesn't have any. The moderate obviously has some, and here is the mild. Mild has a lot more, and that can give us a kind of index per animal, each animal, what tracks have been spared. Now, the next step for us is obviously how this correlates to behavior. And that is a kind of touchy issue, the behavior, because our behavioral assessments usually are not as sophisticated. We use some scales, but there is a lot more to those scales, to the movement. But but let's put that aside, and we use what people classical are using. But I think it can improve on that to do these correlations with more sophisticated behavior. And one of the things we did is then take these nuclei, correlate the sparing to the BMS. Practically, BMS is a large scale from 1 to 9, and then try to see the spare neurons how correlate to a particular BMS, and then draw a kind of general conclusion. It's not telling you really exactly whether this nucleus is really important for the particular behavior in BMS, but I'm just trying to show you where we're going, you know, how the power of doing this. And it turns out, yes, the propriospinal was really important, the sparing of these are the neurons in the cervical. We did the counting on that. And what's interesting was the pedunculum-pontine area was, which is really a mesencephalic area, which is a lot of the focus these days for movement, especially the cuneiform nucleus. But this is pretty close to the cuneiform. So one of the surprises also on this project we did is we did not find any direct projections from the cuneiform. And we know you guys are working in stimulation of cuneiform is one of the new things, like at least even for Parkinson's. We did not find any direct projections. And turns out that is actually correct. The projections to the spinal cord are all indirect. So anyway, these are the correlations we have, and now we want to really solidify them a little bit better with other methods. And here is the mouse brain. I'm just showing you the. Okay, so this is really the main study. So what is next? You know, how we can use this whole brain imaging to the injury in a more sophisticated way. So practically you want to go from the genes to cells to the behavior and how we will approach these. So this is some of the first experiments we have undertaken now. We want to use a more clinical relevant model, which is a contusion injury. And also we want to up our game on the behavior, go away from the BMS. It serves an important function, but is not sophisticated enough to parse out which nucleus involved in a particular behavior. And then also go beyond that to correlate to a kind of neural activity. And I will say how we're doing it is not the most sophisticated way, but is a way towards a more precise analysis of the spinal cord injury. So the way we're going to do here is we're going to pre-train a mouse for 3 weeks for pellet retrieval. So that mouse will have a particular task of how it's going to retrieve a pellet, how it's retrieving it, and using some software like DeepCap-Rod. And then we're going to have for a weekly behavior after after the injury for 6 weeks, have a rehabilitation involved in it. Then we're going to inject the virus. After all these, wait 2 weeks, do a terminal behavior, and then perfuse the animal. And then what we want to do is here is the injury severity, rehabilitation versus neurorehabilitation. So this is not, we're trying to see the variability using rehabilitation or rehabilitation to a particular behavior is not an direct intervention to, you know, of regeneration. And we want to see what is the difference and what nuclei are still have projections, and then at the end correlate that to the activity. So we have cervical, thoracic. Here is the behavioral outcomes: pellet retrieval, ladder crossing, von Frey. In the thoracic, obviously we have to use the BMS. And von Frey is a pain testing test. And So we started this experiment. Now let me talk to you about the neural activity, how we go about it, because we want to correlate not just the sparing to the behavior, but also to the neural activity. Let's see, this is going ahead. Is not progressing. Oh, sorry, there it is. The best way to do it, and that is something like Nirupa does, you know, in their taste models, is to use calcium imaging. This will be really the ideal. And practically this is based on increase. So we know that calcium fluctuations are due to neural activity dynamics and correlate with action potential, exocytosis, and synaptic plasticity. And there are probes that you can do that. So that will be the ideal for us. But we don't have that. And we have the next best of it is, so we want to measure brain activity by detecting a gene. It's called CFOS. So calcium influx activates various signaling cascades that results in gene activation. There are specific genes that get activated, and there are some listed here, like CFOS of NPAS4. Calcium can do both. Fortunately for CFOS, other also stimuli like neurotrophins can stimulate. It's not the most reliable for activity, NPAS4 it is. So these are the two antibodies we want to use after the animal has been sacrificed, retrograde labeled, and then measure this FOS activity. And we want to do it on the whole brain, then go back to the registration and say, okay, here are how the neurons that are spare, and how many of those neurons that are spare have activity based on the particular task, and then trying to draw these correlations. I know there are wide correlations, but if we do enough animals, we can get some interesting answers to that. Okay, so the way we don't have that data yet on the behavior, but this is just a test that we can actually do whole imaging of neural activity on the brain. And the way we did it here is we took a shortcut to see whether it works. And what we did is we use a design receptor exclusively activated by designer drugs, DREAD. And we use this particular receptor, it's a 7-helix receptor. We deliver this receptor using the AAV2 retro by injecting it to the cervical. So this receptor will go to the neurons we just mentioned earlier. Then use an actuator, practically use a chemical, clonazepam in this case. You give it to the mouse by just drinking water, and that will activate the receptor. And what happens to this mouse, unfortunately, is quite dramatic. You know, starts shaking, freezes. So you can see this mouse is having all kinds of behaviors related to this activation of the supraspinal neurons. We did it just because we wanted to upregulate FOS after calcium influx. And here are some of the preliminary data we get. So we can get FOS, we can get the V5, we can see colocalization in some of these. And 2 weeks ago, we were able to also clear the brain. And here it is. This is traveling now. So this is the light sheet traveling through the sections of the brain. Here is the corticospinal, sensory. Now here is the red. Oops, sorry, got frozen. Red. Here is the spinal cord. Let me stop it here. Spinal cord, medulla pons, mesencephalon. Sorry. Again, here. So these are all the nuclei that have been ingested. Here is the FOS. You can't see it, it's very small, but you can see it on the next one. Here is the 3D reconstruction of these. You see medulla, mesencephalo, red nucleus, cortical, sensory. Here will show up. Now they're going to show, here is all the FOS. Obviously the FOS, because this mouse practically has an attack, kind of epileptic attack, FOS will be activated in various areas. You can see here that it's not just the neurons that project to the spinal cord. These, the white ones, are the ones who localize with FOS, and the green, that means neurons that project to the spinal cord are also have the FOS. But as I said, you know, because of this activity, FOS will be everywhere in the brain. And just this is going to finish very soon. And here is just the FOS. Now, so practically what we want to do after this experimental paradigm I just outlined is take the data, register, and then make these correlations. Now, once we have these correlations, we're working on finding intersectional approaches. So practically we want to go back now and using some of these chemogenetic tools, go back to the areas we think are important for this behavior, activate them or silence them. Because we cannot use the AAV2 to do that because it labels all the neurons. We want to specifically label the regions or neurons that we think are important for that particular behavior. And the way we're going to do that, that is also in progress. There are a few ways. 47. Let me skip on this. Another thing we did during this study is practically we wanted to know the identity of these neurons that project to the spinal cord. There are some methods these days where you can isolate single cells and do their sequencing, and that can give you a lot of information based on what kind of genes are expressed, and then you can use that information to classify the neurons, give you some interesting information on their electrophysiological characteristics, how similar to the others, and so on. So we did this study. Practically, we retrograde label, we micro dissect the areas that project to the spinal cord, we sort the neurons, and then these get subjected to sequencing. Turns out this is really specific. We know that only excitatory neurons pick it up. None of the other lineages in the brain are labeled, so we know it's specific to the neurons. We know that both corticospinal glutamatergic that have transporter 1 and 2 are labeled, and very few of the inhibitory. We further classify the neurons. Even though we have 69 regions, doesn't mean all the neurons are different, could be quite similar. So here is just a clustering we did of these neurons. So this is the paraventricular hypothalamic, this is the corticospinal, Raphe. So we even at the level of the transcriptions, we can separate them. The HB means hindbrain. The hindbrain has been really difficult to separate them, correlate them to the particular nuclei formation, for example, gigantocellular or some lateral reticular and so on. And here is some of the confirmation. Now, so we want to get those specific labeling to the neurons. There are two ways we were attempted to do that. There are two more some AVs that are retrogradely transported. This is the MNM 004, 008. We made the capsids for this, and we are having a doing a direct comparison of these. The reason is because the MNM08 is less, apparently, according to the paper, is less refractory to particular neurons in the brain. So we think that perhaps we can also label the inhibitory. So these are ongoing experiments. This is the M&M 004 side-by-side comparison. This is just one first run. Probably are quite similar. So we think that maybe these, even though the sequences of the capsid of the recognition of the receptor are, the amino acids are different, probably they bind to the same receptor. We don't know about the MNM8, so that is an ongoing project. Now the other aspect is trying to use specific promoters or enhancers. So practically use regulatory regions that drive the expression of genes in specific subpopulation. And that is something we have attempted. I won't go through the method, but that's some of the early results. For example, we took this piece of DNA, we made a new virus, we put, we don't have a general promoter, we have this enhancer, X, we injected it, and this one seems to be specific to the corticospinal. We don't see any other neurons getting a label. This is cytoplasmic, so these are just projections, so it doesn't mean labeling of the neurons. So that is something we're really interested in pursuing towards this problem. So that is my conclusion. I take any questions. Sorry, I tried to pack too much on it, but I thought, maybe, people in neurosurgery or other people in my approach to know what we can do and, the power of these methods. And I'll leave it up for discussion and I just leave it here. I take any questions.
Thank you, Pontalis. Great presentation. A really nice continuation discussion we had earlier this morning on the connectome, and now you're obviously digging much deeper in terms of the genetic strategies and things of this nature that can be associated with these tracks. It's open up for discussion. Nirupa?
Yes, Pantelis. Hi, good morning.
Good morning.
Okay, good. So you can hear me. Wasn't sure. So my question is about the variable. Okay, so I expect that the injuries, I know you guys have incredibly well standardized injury models, but I'm a little bit puzzled about why the same severity, say a mild injury at the cervical level.
That was a lumbar, sorry.
Sorry?
It was a lumbar, sorry.
Okay, at the lumbar region, why should it consistently cause a decrease of some areas, and because you're making it a percentage of the uninjured model, which is good, but then I would expect that the variability should only come from the placement of the injury itself rather than an area. I'm really confused by that. I expect it. So if axons are severed in a particular part of the spinal cord, then that projection area should be decreased.
Yeah.
And if there's variability across your 10 mice where you did this injury, then it shouldn't show up as a variability for a region. So
yeah, so that is a good question, but that is what we're really trying to attempt. So you saw the data as a whole. So and this is a problem in the field, and I think some people have verbalized it recently. In a paper, they call it the spinal cord injury paradox, where, there could be an injury that looks really bad, but the behavior is much better than the one that looks very good. The area of injury looks, mild, but the severity of the behavior is high. So I think that is what we're trying to attempt to address.
I see.
So by analyzing each mouse, not as a whole, I mean, we have to present the data here as a whole.
Yeah.
Taking each mouse now and looking at that mouse to a particular behavior, right? So that is if we had 100 different behaviors, then we can make this correlation better. But because so if we do a retrieval task, then we can start making these to a particular behavior. You know, is these neurons that dropping on area A are more preserved and you have a better grasp, or versus that. Remember, that is a correlation. At the end, which that is something I talked at the end of the presentation. Once we have the correlation, it's still a correlation. We don't have a causal link. Then once we did the correlation, we would like to go back to that particular area or set of nuclei and deliver a protein that activates them or inhibits them. So for example, if we have area A and it has a particular grasp and then we inhibit it, does the grasp still there by inhibiting just one nucleus or two nuclei, right? So there's going to be a variability, there will be a correlation, but at the end, we need that causal link.
Yeah. Okay, that makes sense. I have a small technical point that I can add, and then I'll relinquish the microphone. Sorry, Dalton. But the in situ hybridization or whatever it is for the CFOS is challenging, and you should consider using the trap mice, which have a really, really strong, very clear signal, which will survive your clearing nicely.
Yeah, so a good question. Yeah, we consider all of these. And in fact, when we put the grant, we have it as an alternative. So what are the reasons of the TED? I think mainly it's a logistical. So part was, I don't do those studies. So let's make sure, I talked with Murray and he was not negative, but he says, oh, I need to breed them. Need to, I think it was more a certain reluctance of introducing a new mouse. The other thing is, I have to tell you, I did work, so there are different generation of these mice of the FOSS reporter. I did work on one trying to help somebody at UCLA, and it was and it's actually exactly the same. He was doing locomotion and then he will send me the spinal cords of the brain and start doing the staining and surviving. We had some technical problems, so I think it's a good suggestion, but I'm not so sure how well it will work. But we were considering it. It's an alternative.
Okay, thanks.
Yeah.
Okay, great discussion. I've got to go to another Zoom, but Brian, did you have a question? I see your face. Go ahead. And then
yes.
I'm gonna...
Can you hear me?
Yes, go ahead.
Yeah, so I was just wondering about the FOSS. I'm not clear exactly how you are actually tagging them or labeling them. So FOSS is expressed, but are these then, are you then introducing antibodies onto the tissue?
Yes, so
how far can that penetrate in the brain?
Penetrates in all the way in.
Can you do it on large brains?
Good question. Could be try.
I'll talk to you later about that then.
So okay, here is really hard to see it. Okay, the penetration is a technical issue. The penetration is good. The penetration is not homogeneous. That means you cannot make statements of intensity. If it's more intense, there is more force because there is a kind of, but we can detect force all the way. It's just a little bit weaker, but we can detect it. And yeah, it's not a problem.
Okay, great. Thanks.
Yeah. Thank you guys for waking up and listening to me. Thank you.